Good evening, and welcome to the NASPGHAN Foundation CME webinar on Masqueraders of IBS. I am Dr. Barry Warshall, and I'll be chairing this program tonight. I'd like to thank the NASPGHAN Foundation for sponsoring this webinar, NASPGHAN for providing the accreditation, and to Dynax and QOL Medical, which provided support for this program. I'd like to give a few quick instructions before we start. There are a number of interactive areas beneath the main webinar window. You'll need to scroll down to see them. There is a chat area where you can comment or ask questions. Please submit your questions at any time. There's no need to wait until the end of the program. At the conclusion of the presentations, we will answer as many questions as time allows. Below the chat area are 4 participant polls. Please don't respond to them until prompted, as we will present each poll question during the program. At the bottom of the web page is a link that allows you to download the full slide set. And also at the bottom of the page is an important link to receive your CME credit. And finally, we want to invite you to participate in our chat room, which will remain open for 1 hour after the close of the program to allow participants to share cases and comments with each other. It will be open to all participants and will not be moderated. Next slide. And now I'd like to introduce the faculty. Tonight, our presenters will be Dr. Sam Nurko from Boston Children's Hospital, Dr. Robert Schulman from Texas Children's Hospital, and Dr. Ivor Hill from Nationwide Children's Hospital. And our CME content was reviewed by Dr. Melanie Greifer of Cohen's Children's Hospital in New York. Next slide. I'd just like to briefly go over the objectives of the program tonight. We're going to describe the symptoms of functional bowel diseases and aim to understand the Rome-3 criteria for diagnosing irritable bowel syndrome. We want to try to recognize diseases that mimic IBS, including food allergy, hereditary angioedema, congenital Sucrase-Isomaltase deficiency and other disaccharidase deficiencies, and non-celiac gluten sensitivity. As well, we want to understand a diagnostic approach and the limitations of that approach for identifying patients with these conditions. And now, I'd like to introduce our first speaker, Dr. Sam Nurko, who will focus on irritable bowel syndrome. Sam?
Thank you, Barry. Good evening, everyone, and welcome to our webinar. As can be seen in the slide, pain is something that really has a very significant toll on quality of life. The problem with pain is a very subjective symptom and has to do a lot with personal perception. As can be seen in the next slide, abdominal pain and other functional disorders have a very significant impact in our clinical practice, and they account for more than 50% of the consultations in pediatric gastroenterology and about 2 to 4% of all general pediatric office visits. There's been a few epidemiological studies that have tried to see how common it occurs. There's been a study from Jeff Hyams that showed a prevalence of 8% in middle school children and 17% in adolescents. More recent studies, in a population cohort of almost 14,000 children, chronic abdominal pain was found in 11.8% of those around 6 years of age, and it was less common at ages 2 years and 3 years, but was still prevalent, as can be seen, 3.8% and 6.9% respectively. In an adolescent study of 20,000 patients, which was a cross-sectional study, 3.2% reported daily abdominal pain. 15% reported pain that occurred more than twice a week, and 14% reported pain as moderate in frequency, which shows us this is something that's very common. Trying to see what's the impact on daily life and how common it is, there was a recent study from Miguel Saps also, in which he went to a school and applied weekly questionnaires, and what they found was there was a weekly prevalence of pain of about 38%, and 90% of the children reported at least one pain episode. The pain persisted for 4 weeks in 52% of the respondents, for 8 weeks in 24%, and 12 weeks in 18%. And we're going to know the importance of these timelines when we diagnose functional abdominal pain. Now, most importantly, this abdominal pain was associated with a poor quality of life, more psychological comorbidities, more school absenteeism and parental work absences, and a very high cost, showing us that this has a major impact in our practice. Now, the problem with functional abdominal pain is that when we face a patient, it's our role as the pediatric gastroenterologist to decide what type of pain am I dealing with. Is this a patient that indeed has functional abdominal pain, or is this a patient that has an underlying organic disease that needs to be diagnosed? And as can be seen in the next slide, on the left panel, this is the dream of every physician. We want to find the reason for the pain, take it out, and cure our patient. And as we know, that's not the model that is followed when we deal with functional abdominal pain and irritable bowel syndrome. We need to think differently, as we have no biomarkers, we do not have a blood test, we don't have a structural abnormality that we could do a biopsy for. And the problem with the functional abdominal pain is that it is a symptom-based diagnosis, which sometimes it's hard to understand for the families. One of the frameworks I like to use is to tell the families the difference between having a problem in the hardware, which would be more like an organic disease, versus the software, which is the way things are functioning and perceived, which is really what the functional abdominal pain and irritable bowel syndrome are. As can be seen in the next slide, to try to make a symptom-based diagnosis, there's been groups of experts that have tried to see what's the best definition for pain, both from an epidemiological and a research perspective. And all of us know the most common criteria used are what's called the Rome criteria, which now are in the third iteration, and soon there'll be a fourth one. And this slide shows you the diagnostic criteria that have been mentioned as a way to diagnose irritable bowel syndrome. There has to be abdominal discomfort, or there has to be pain associated with 2 or more, at least 25% of the time, of the following characteristics. The pain has to be improved with defecation. It has to be an onset associated with a change in the frequency of stool, an onset associated with a change in the form or appearance of the stool, and most importantly, and this is where our seminar comes to, there has to be no evidence of an inflammatory, anatomic, metabolic, or neoplastic process that explains the pain that the subject is having. And this looking for the organic disease is what leads to many unnecessary tests, but on the other hand, is something necessary when we suspect there's an underlying condition. Importantly, as you can see in the lower part of the slide, the criteria for irritable bowel syndrome need to be fulfilled a certain timeline. So the criteria need to be at least once a week for at least 2 months prior to the diagnosis. As can be seen in the next slide, not all patients have problems associated with bowel movement or with other symptoms. So there's a criteria that we call functional abdominal pain, which mostly includes episodic or continuous pain. When there's no criteria to diagnose the irritable bowel syndrome or other of the functional criteria, and again, we come to the premise that there has to be no evidence of inflammatory, anatomic, metabolic, or neoplastic process. What this means, if we go to the next slide, is that the premise of Rome is that functional pain occurs in the absence of organic pathology. And when we face a patient in clinic, our role is to decide, do we have enough signs and symptoms to diagnose abdominal pain? Are there any alarm signs that should prompt us to do more workup, or are we dealing with another underlying condition? And this slide tries to show the most important conditions that need to be taken into account in the differential diagnosis. We need to be sure there's no peptic disease, gastroesophageal reflux, infectious processes like parasites like celiac disease. The role of H. pylori is controversial, but in certain areas of the world is very permanent and associated with pain. Inflammatory bowel disease, celiac disease and food intolerances that we're going to talk more later, the presence of gallstones, pancreatitis, renal problems, endometriosis and ovarian cysts, and the list could go on and on. I could spend the whole hour just talking about the differential diagnosis. Because it's so complex, and because most patients that we face have only functional disease and don't need a big workup, the Rome Committee proposed a series of alarms and symptoms and signs that should prompt you to do more workup. And those can see in what's called here Table 2. And as you can see, those are the signs that suggest that there may be an underlying condition, like persistent right upper quadrant or right lower quadrant pain, dysphagia, persistent vomiting, gastrointestinal blood loss, nocturnal diarrhea, family history of inflammatory bowel disease, celiac disease, or peptic ulcer disease, pain that wakes the children from sleep, arthritis, perirectal abscesses, involuntary weight loss, deceleration on linear growth, delayed puberty, or unexplained fever. It's important to remind the audience that recent studies have shown that many of these alarm signs can also occur in functional diseases, so future prospective studies are really going to delineate what are the most significant, sensitive, and specific alarm signs that we should use to do more workup. As can be seen in the next slide, however, we are always worried that we're missing the more obscure diagnosis and the more difficult diagnosis to make. And this is something very important, as even though we're trying to exclude an organic disease, the message to our patients has to be that most patients with functional pain do not require a major workup, and we do not need to look for the most obscure diagnosis most of the time. The most important thing is a close follow-up and to be able to see how the patient is doing before we embark in multi-million-dollar workups that are going to reinforce more the organicity of something that's probably functional. Of course, for our patient, the disease is 100%, so if we happen to have a patient in front of us that indeed has an underlying condition, for that patient, the statistics do not matter. So he's dealing with an organic disease, which for him would be 100%. So what are the recommendations? What type of workup should we do to try to decide who are the patients that merit more workup? And as can be seen in the next slide, the initial evaluation that's suggested in general has to follow certain principles. The most important thing, the approach to a patient with pain has to be that we are trying to do tests in the context of trying to find triggers of the pain, not the reason for the pain. And it's a very subtle difference, but it makes a big difference in the perception of the families when the tests we're doing are negative, because we don't need to do more tests to find the reason. We're just trying to find the triggers. And as can be seen in the first bullet, the history and the exam should direct the workup. We need to find triggers and do reassurance. Of course, there has to be epidemiological considerations. If we live in an endemic area of Giardia, of course, that has to be diagnosed, or an endemic area of celiac, so more workup needs to be done for that. It's recommended that an initial screen should include CBC, sedimentation rate or other inflammatory markers, tests for occult blood in the stool, celiac testing, liver function, amylase, lipase, and a basic chemistry, urinalysis, and as I mentioned before, the celiac screening, and stool for ovum parasites and H. pylori, depending on the area of the country or the world where you are. It has to be said that there's no studies that have documented the sensitivity and specificity of this approach in the evaluation of children, and these are studies that are ongoing. If you go to the next slide, you can see that after we do the initial testing, there may be secondary evaluations that may be needed. And again, they need to be done in the context of our differential diagnosis of how likely is the disease. So we are talking about breath tests to try to look for lactose malabsorption or bacterial overgrowth. And in the absence of specific signs and symptoms, there's many studies that have shown that imaging, like plain X-ray of the abdomen, ultrasound, CT, MRIs have a very low yield, as well as endoscopic and colonoscopic testing, as well as impedance testing, and many other tests. And as all of us know, there's many tests we could do, but we have to be very careful not to overdo it. As can be seen in the next slide, however, we conclude that it has to be a directed evaluation and history according to the genetic background, the epidemiology, and the environment, and all this needs to be used in the context of the biopsychosocial model, and we need to consider the cost effectiveness. I want to show you in the last slide briefly what we talk about the biopsychosocial model, and as we can see, visceral hyperalgesia is at the center, and our work is to try to understand what the genesis of this hyperalgesia is, taking into account the genetic predisposition, the early life events, as well as all the sensitizing medical events and the psychosocial events that could lead to our disability. As can be seen in the next slide, I want to conclude then, reminding you that functional GI disorders are common. They have to be a symptom-based diagnosis. We need to look for an underlying disease or triggers. We have to be very reassuring. We need to follow the biopsychosocial model, and all the testing needs to be directed by history, examination, genetic background, epidemiology, and the environment. And we need to do it in the context of the biopsychosocial model, and always think about the impact that our testing is going to have on cost and on the child. I would like now to introduce our next speaker, Dr. Barry Warshall, who will speak with you now about the immunological conditions that may be confused for IBS. Barry?
Great. Thank you, Sam. On the next slide, we have listed a number of immunologic conditions that can present like IBS. These include food allergies, vasculitides that involve the intestinal tract, like Henoch-Schönlein purpura, and hereditary angioedema. Tonight we're going to discuss food allergies and HAE. Next slide. Well, oftentimes we're faced with a patient that has functional complaints, and the parents are concerned that the patient is allergic to certain foods. And food allergies are definitely on the rise. About 3 million children are affected, or 4% of the pediatric population in the United States. However, the public perception of food allergy is much greater. Almost a third of parents believe that their child has a food allergy, and 25% of adults feel they have a food allergy. Next slide. And this slide really kind of shows us why. Almost any symptom or sign can be part of the presentation of a food allergic individual. I draw your attention to the upper right-hand part of the screen, where you can note the lower GI symptoms and see that all of them can be IBS symptoms except for hematochezia. I also want to emphasize what's in the lower left-hand part of the slide, and that is an important part of the history taking, is to ask about oral GI symptoms, because if they're present, they can often help differentiate a patient who might be food allergic from a patient who may have IBS. Next slide. It's important to recognize that allergists and GI doctors will see patients with suspected food allergies, and that our perspectives in our testing differ. For the most part, the allergist is concerned with immediate-type reactions that are IgE-mediated or anaphylactoid in nature, like FPIES or hereditary angioedema. The gastroenterologist is usually asked to consider immune reactions to food that are cellular-mediated. So the approach is different. But there will be overlap. That is to say, there will be patients that may have both types of reactions ongoing. Next slide. Now it's time to present our first interactive participant poll. The poll question is displayed in the main window, but you must scroll down to submit your response in the polling area beneath the main window. And then we'll report the results in a few minutes. So our question is it important? It's important to consider food allergy as a cause of IBS-like symptoms in 1, any patient with IBS symptoms, since food allergy is commonly misdiagnosed as IBS. 2, when the patient has positive skin prick test to a food antigen, since this is definitive proof of a food allergy. 3, in a patient with IBS-like symptoms and a strong family history, a strong history of atopy. Or 4, in a patient with the histologic finding of any number of eosinophils in the stomach, duodenum, or colon. Please go ahead and vote on that, and we'll come back to it in just a short period of time. Next slide. When considering food allergies affecting the GI tract in children, and in particular beyond the first year of life, a unifying concept is that they rarely occur as an isolated event. They are most often seen with other allergic phenomenon. Many to most patients will either have asthma, eczema, respiratory allergies, or some combination thereof. Without these conditions, food allergy is less likely to be a cause of a patient's symptoms. Next slide. The allergist will commonly test for immediate-type hypersensitivities using skin prick test, but we can essentially do the same with blood immunocap testing. But the important concept to understand, and where a lot of confusion is generated, is A negative test does not rule out allergy. If negative, it is about 90% sensitive at ruling out IgE-mediated reactions, but it says nothing about cellular-mediated reactions. So, as well, if positive, it doesn't necessarily mean that the patient is allergic. The test identifies a sensitized individual, but that doesn't mean that they are reactive. That is to say, a positive test is about 90% sensitive, but only 50% specific. So you will overestimate food allergy half of the time if you only rely on the test result. If positive, to prove allergy, you need to document a reaction to the food. Next slide. So going back to our poll question, the correct answer was answer number 3, and 55% of the participants chose that as their answer. Again, you want to look for food allergy in the context of other allergic diseases. Next slide. Now, as gastroenterologists, we're more likely to see patients suspected of having cellular-mediated food allergy, and that means we're looking for evidence of tissue inflammation. Most often, we're looking for eosinophils or lymphocytes. But even in cases of negative endoscopies, we're often trialing food elimination diets for diagnostic purposes. So remember, when trying an unblinded dietary elimination, milk is the most common offending allergen, followed by soy, wheat, eggs, nuts, fish, and shellfish. But when tried in a blinded manner, only about 1/3 of suspected food allergic patients will actually have that suspicion confirmed. Again, food allergy is not quite as common as it's believed in the population or believed among patients. Next slide. Now, while I was rigorous about allergy testing in the previous slides, I want to be just as rigorous about endoscopic findings, particularly histology, and remind everybody that tissue beyond the esophagus can normally have eosinophils. So be careful and consult with the pathologist when they identify eosinophils in the stomach, small intestine, or colon. Pathologists rarely count eosinophils in these other sites. So do not accept a pathology report that suggests an increase in eosinophils in tissues without careful analysis. Next slide. Now, I'd like to present a brief case that I saw last year. LS is a 6-year-old girl with a 1.5-year history of intermittent abdominal pain. She's asymptomatic for months at a time, then develops intense abdominal pain with only occasional vomiting, and this would improve over 1 or 2 days and resolve over 1 or 2 weeks. She was seen by several doctors with multiple negative tests and was given the diagnosis of food allergy by one physician and stress-related IBS by another, as the parents thought she was kind of stressed out. Dietary changes, increase in fiber, anticholinergic had no effect on her symptoms. And a psychiatric consult was then recommended, but before going to that, she came to seek another opinion. We've initially considered abdominal migraines, but a neurologic consult was obtained, and they felt that this was very unlikely. We did a variety of testing at the time that she was having pain episodes, which was entirely unremarkable, and an upper GI series and an EGD were normal. Next slide. We obtained a C4 and C1 inhibitor level, and both were found to be low. So her diagnosis is hereditary angioedema, or HAE. And the previous diagnoses of food allergy or IBS were really inconsistent with her history. These entities tend to be more chronic in nature, not episodic and discrete in episodes as this young child's were. But really, it's not a very common entity and one that we rarely think about. Next slide. It is a rare disorder. It's seen in about 1 in 10,000 to 1 in 50,000 incidents. 75% of the cases will have a family history, therefore, hence the hereditary part of the name. 20 to 25% of cases, however, are spontaneous. Classic HAE presents with swelling, edema, particularly of the face, larynx, extremities, and abdomen and genitals can also be involved. This is why most of the cases are seen by allergists. Abdominal pain is commonly seen, and can be in more than 90% of cases. But what's particular in the pediatric age range is that episodes can be only abdominal in nature. Next slide. Now, this slide depicts the multiple points in the complement cascade where C1 inhibitor acts as a brake, stopping the progression of activation. When it is absent, as in the next step, then complement activation proceeds unimpeded. This results in the next step an elevation in bradykinin levels. And it's bradykinin that leads to the edema that is classically seen in this disease. Next, it's followed by C2 and C4 activation. Next, that activation leads to a lowering of C4. So in the next table, what is shown is the diagnostic approach for this entity is to draw C4 levels, C1 inhibitor levels, and C1 functional activity, C1 inhibitor functional activity. In the so-called type 1 disease, you'll see C1 inhibitor levels low. In type 2 disease, you see normal C1 inhibitor levels, but low functional activity. So if you suspect the disease, send a C4, a C1 inhibitor level, and functional activity. The reason that this is important to recognize is that this entity has specific treatment strategies, either for acute attacks or preventative attacks. That is, administering C1 inhibitor. Next slide. So in conclusion, there's a lot of overlap in the symptoms of food allergy and IBS, but think about food allergy more in the patient with a strong history of atopy. And remember, the public perception far exceeds the reality of the incidence of food allergy. Allergy testing is only part of the diagnostic picture, and any positive test has to be confirmed with an attempt to correlate it with symptoms. HAE is a rare but treatable cause of recurrent attacks of abdominal pain and vomiting with or without swelling. Next slide. And now I'd like to introduce our next speaker, Dr. Robert Schulman, who will speak to us tonight about carbohydrate malabsorption and masquerading as IBS diarrhea predominant.
Thanks, Barry. It's a great pleasure to be with everyone tonight. Before I begin, I'd like to ask a quick poll question, which we'll see on the next slide. And that is, when it comes to carbohydrate-induced diarrhea, most likely to contribute to the diagnosis would be number 1, duodenal biopsy with disaccharidase analysis, 2, a hydrogen breath test, 3, treatment with rifaximin, 4, a diet or symptom record, and number 5, stool examination for ovum parasites. And we'll come back to that in just a second. Remember to scroll down to enter your answer for this poll question. So on the next slide, we look at the clinical characteristics comparing IBS-D, that is IBS diarrhea predominant, with carbohydrate-induced diarrhea. And as we can see very quickly, they almost perfectly overlap each other. As Sam nicely went over, with IBS, we see the patients have abdominal discomfort or pain and changes in stool form, so they might have diarrhea. In this case, of course, that's what we're talking about, but they also might have constipation. And stool frequency might either be less or more. In the symptoms of carbohydrate-induced diarrhea, those patients also can get abdominal pain, discomfort, and or bloating. They can also have flatulence and, again, diarrhea. So clinically, it can be difficult to distinguish these two types. On the next slide, one thing that can be helpful is to objectify the stool reporting. And that can be done with the validated Pediatric Bristol stool scale, which has been validated down to children 6 years of age, as long as you read those descriptors to the children that are accompanied by pictures. So the stools are rated from 1 to 5, with 1 being the constipated stools, and 5, of course, being diarrheal types of stools. So that can be helpful getting that report from the children as well as the parents. I want to stop here a second and ask Barry to share the poll results on the next slide.
Well, it was interesting. The correct answer was diet and symptom record, answer number 4. 42% of the participants chose that as the answer. 48% chose answer number 1, duodenal biopsy with disaccharidase analysis.
Okay. Let's move on to the next slide, and we'll come back to the polling results, I think, probably in discussion time. So on the next slide, we talk about carbohydrate malabsorption and what's the pathogenesis of symptoms. So naturally, if malabsorbed carbohydrate passes from the small intestine into the colon, as we see on the next slide, that induces an increased osmotic load in the small bowel and then on into the colon. On the next slide, we see that osmotic load is going to draw fluid into the lumen, and that will increase the luminal fluid volume. Then what results, as we see in the next slide, are the symptoms of diarrhea. And these are what we're talking about now are the physiologic effects of this malabsorbed carbohydrate. Now, in addition, as the increased luminal fluid occurs, on the next slide we see that causes luminal distension, and that's partly what's responsible for the symptoms of bloating and pain. On the next slide, since this carbohydrate is being malabsorbed, it's going to wind up in the colon and fermented by the bacteria in the colon. And so we have an increase in fermentable substrates that also adds to the osmotic load. But in addition, as we see in the next slide, induces gas production, which of course on one hand is the basis of the breath hygiene testing that we might do to diagnose these disorders. But that increased gas production, as we see in the next slide, is also going to contribute to luminal distension and pain and bloating, and also to gas production as well. Interestingly enough, finally on the next slide, there are some interesting new data suggesting that in addition to these effects, there might be also some induction of inflammation by malabsorbed carbohydrate. And we anxiously await future studies to evaluate that in more detail. So on the next slide, we'll turn to our first disaccharidase deficiency, which is lactase deficiency. And as you're probably well aware, that's divided into two categories, primary lactase deficiency and secondary lactase deficiency. Congenital lactase deficiency is an extremely rare disorder, essentially a reportable disorder that occurs obviously from birth. We're much more familiar with developmental lactase deficiency or hypolactasia, which is related to ethnic background. And so populations such as Asians and blacks tend to have low lactase activity, which can occur starting around 2 to 3 years of age, and Western Europeans and other populations also will develop lactase activity, oftentimes a little bit later age. Secondary lactase activity can also occur in the presence of mucosal injury from celiac disease, infection, and so forth, or from bacterial overgrowth. As we look on the next slide, though, there's a similar frequency of lactase deficiency in patients with IBS as compared to healthy controls. So IBS patients are not more likely to have lactase deficiency. However, patients with IBS are likely to have greater sensitivity to the effects of lactose malabsorption. And we'll show that a little bit more on the next slide in a second. So the deficiency of lactase activity is usually diagnosed by hydrogen breath testing, and there's pretty good agreement among experts that a dose of 1 gram per kilogram of lactose should be used for the breath test, up to a maximum of 25 grams, and a rise of 20 parts per million of hydrogen over the baseline value, the zero-time value, is diagnostic of lactase deficiency. But it's extremely important to remember that malabsorption of lactose does not necessarily equate with lactose intolerance. So in other words, with lactose intolerance, you have symptoms that develop as a function of that lactose malabsorption. Many patients have lactase deficiency and have lactose malabsorption, but don't necessarily develop symptoms or significant symptoms. So one way to evaluate for intolerance, lactose intolerance, is actually a trial of dietary exclusion of lactose out of the diet. So as we see on the next slide is a very interesting study in which this is an adult study, but they administered in a double-blind randomized fashion different doses of lactose to these adults. And these adults were patients with IBS diarrhea predominance and also controls. And as you see on the left side of the slide, there was a similar prevalence as determined by hydrogen breath testing of lactose malabsorption between the two groups. On the other hand, when they evaluated these patients, and again this was done in a double-blind manner, for the presence of lactose intolerance, in other words, patients who actually developed symptoms of pain, bloating, and so forth, it was the IBS-D patients that had a greater response in terms of intolerance symptoms than did the controls. So IBS patients respond differently to malabsorption than do healthy controls. On the next slide, we look at dietary fructose. Dietary fructose, most of that comes from sucrose in our diet and high fructose corn syrup. The remainder is from free fructose and fructans, which are linear or branch-changed fructose polymers. And that accounts for probably about 10% of our total intake. And most of that comes from pizza, pasta, cakes, and so forth, as listed on the slide. In the United States, our intake of dietary fructose is about 49 grams per day. And unfortunately, as we know from the obesity epidemic, that comes about 2/3 from soft drinks and so forth, and about a third from fruit. On the next slide, there are 2 points to remember when it comes to the physiology of fructose or fructose malabsorption. The first is that glucose actually enhances the absorption of fructose. So when glucose and fructose are together in the diet, the glucose will increase the absorption of fructose. So malabsorption then occurs if there's more fructose than glucose present in the diet. And secondly, sorbitol greatly inhibits the absorption of fructose. Therefore, when we look at the diet, we see like pears, apples contain more fructose than glucose, and we can start to understand why that might engender fructose malabsorption. And even more so, there's substantial amounts of sorbitol in pears, apples, cherries, and plums, and that's why they oftentimes have the reputation of inducing diarrhea potentially. And high fructose corn syrup, which you find in many food products, depending on the type of high fructose corn syrup, there may be more fructose than glucose in those products as well. And again, they may engender malabsorption as a result of that. On the next slide, we see the real problem with talking about fructose malabsorption. And that is, if you give somebody a high enough dose of fructose, you can engender malabsorption in anybody. And so there appears to be a similar frequency of fructose malabsorption in IBS patients compared with healthy controls. But again, give anybody enough fructose and they'll get diarrhea. So again, as we saw with lactose, it's probably the hypersensitivity to the colonic distension that separates IBS patients from non-IBS subjects. So they're both going to absorb fructose to the same degree, but because of this visceral hypersensitivity, the IBS patients are going to have symptoms. Unfortunately, there's no standard for breast testing to evaluate for fructose malabsorption. And so the thing that probably works the best is a trial of dietary exclusion. And you'll hear about the low FODMAPs diet a little bit later when Dr. Hilt speaks. On the next slide, we talk a little bit about congenital Sucrase-Isomaltase deficiency. And again, as you're probably all aware, this is caused by mutations in the gene encoding for sucrase and isomaltase. So it results in essentially absence of sucrase activity, which means, of course, that you can't digest sucrose. But the isomaltase activity can be variable. And so what that means then is the ability to digest starches is also variably affected. The typical presentations in infancy, as we might expect after weaning, when we start to introduce sucrose and starch-containing foods. As you see on the next slide, there's some interesting old data that suggests that perhaps 2 to 9% of the adult population may actually be heterozygotes for Sucrase-Isomaltase deficiency. And again, these are old data, but it's just that perhaps they actually might have varying degrees of sucrase deficiency, which may result in milder symptoms. So there may be a population of kids out there as well that actually have mild degrees of Sucrase-Isomaltase deficiency with milder symptoms, but still may, again, present clinically. There's ongoing studies now to try to tease this out a little bit more and understand better whether or not this is actually truly exists or not. On the next slide, we see, number one, history is key for making the diagnosis of congenital Sucrase-Isomaltase deficiency by looking at the relationship to the diet, and certainly keeping a diet record can be very helpful in this regard. Breast testing can be of some value, but it's probably only helpful in the classical deficiency. Again, some disagreement about the dose that one should use, but somewhere between 1 to 2 grams per kilo, probably a maximum of 25 grams, and again, a rise of 20 parts per million over the baseline hydrogen value being suggestive of having that deficiency. Importantly, though, the patient should develop symptoms with the breath test. So in other words, it's not just the rise in the breath hydrogen, but the patient might have bloating, diarrhea associated with the breath test, and that would certainly be more confirming for the diagnosis. Intestinal biopsy with disaccharase analysis is usually not required in this condition. Treatment of carbohydrate-induced diarrhea really is diet, diet, and diet. In the case of lactase deficiency, you can also use a lactase enzyme that can be bought over the counter, that can be taken with the meal and has to be taken immediately prior to the meal to be most beneficial. For fructose issues, really the only solution there is dietary exclusion. For congenital Sucrase-Isomaltase deficiency, certainly attention to diet is important, but there is a sucrase replacement either in the form of lyophilized baker's yeast, which is very cheap but doesn't taste that great, or saccharosidase, which tastes better but is expensive. It's important to remember, though, that both these products only replace sucrase activity. So patients will be able to digest sucrose, but they still may have issues with starch digestion because it does not replace the isomaltase activity. So in conclusion, then, there's a large overlap in the clinical presentation of IBS and carbohydrate-induced diarrhea. Really, history and diet records are really the mainstay for helping make the diagnosis of these disorders. So let me now turn the program over to Dr. Ivor Hill, who's one of the kingpins of gluten, and he'll talk to us about IBS and non-celiac gluten sensitivity. Ivor.
Thank you, Rob, and good evening to all our participants. I'm going to start with the next poll question, so if you could scroll down to the bottom of the screen to answer this. It's a simple question with a true or false answer. The question is, dietary manipulation improves symptoms in many people with irritable bowel syndrome. So if you could make your choices, we'll come back to the answer in a minute. Our next slide. So does diet affect irritable bowel syndrome? So historically, people who with irritable bowel syndrome have attributed their symptoms to what they eat for many, many decades. And this is obviously because when they do eat, that's what precipitates their symptoms, and so they've naturally attributed it to what they're eating, whereas it may actually just be an exaggerated gastrocolic reflex. But nevertheless, this has resulted in a lot of people eliminating certain foods from their diets and sometimes ending up with very restrictive diets. However, there is some evidence that if you have a prolonged fast, your symptoms of irritable bowel syndrome will in fact improve dramatically. So obviously there's some relationship to eating and irritable bowel symptoms. So if you look at the commonly perceived culprits, the ones that have been most frequently implicated are lactose, dairy products, fructose, as Rob Shulman's told us about, and other carbohydrates. And now more recently, gluten has become the culprit that many people are attributing their symptoms to. And as you know, this has become the new fad diet. And if you look on the next slide, you can see how things have changed over the last decade. Where in the early part of the decade, the low-carbohydrate diet was very common. That has now faded out. The fat-free diet has stayed more or less the same. But there's been a progressive rise in the amount of people that are following a gluten-free diet. And it's now projected this is going to become a over $6 billion industry. That might even be a conservative figure. So many people are following a gluten-free diet, whether for medical reasons or not. We'll deal with that in a few minutes. Can we then come to the results of the poll question? I'll ask Barry to just give us what the results were.
So our answer was true, and 82% of the participants agreed, with 18% believing that the answer to the question was false.
Thank you, Barry. So let's start off with what is non-celiac gluten sensitivity. The definition that is out there at the moment is that this is a condition that has symptoms that improve on withdrawal of gluten from the diet in the absence of evidence for celiac disease or wheat allergy, and that's critical. So there are negative serological tests for celiac disease, negative allergy tests, and if they happen to have a biopsy, that will be normal. There are, unfortunately, no markers to test for non-celiac gluten sensitivity, and it really is a diagnosis of exclusion. You first have to make sure that you've excluded celiac disease and wheat allergy before you can really consider the diagnosis of non-celiac gluten sensitivity. So what are the symptoms of non-celiac gluten sensitivity? If you look at our next slide, this is comparing the symptoms of irritable bowel syndrome with those of non-celiac gluten sensitivity, and as you can see, there's a significant overlap, so the two can be very confused. Both have abdominal pain and discomfort. Both have changes in defecation. There's relief on defecation. There's abdominal bloating. So it's quite easy to confuse the two conditions. So let's turn to the next slide and say, well, what is the evidence for non-celiac gluten sensitivity causing irritable bowel syndrome? There's been a number of papers, but I'm going to quote two. The first was that from a group in Australia. The lead author was Besakiski. What they had is a total of 34 patients who had self-diagnosed themselves as being sensitive to gluten, features of irritable bowel syndrome which improved when they went on a gluten-free diet. They divided these patients up into two groups, and in a double-blind placebo-controlled food challenge trial, they fed the one group muffins that contained gluten, and the other had muffins that didn't contain gluten. And those that received the gluten had a much higher frequency in deterioration of their symptoms, 68% to 40%, suggesting that there was a true entity of non-celiac gluten sensitivity. An even more rigorous study is in the next slide. And here, what these individuals did, they talk about a wheat hypersensitivity rather than a gluten sensitivity. They looked at 920 individuals who had diagnosed themselves as having a gluten sensitivity plus, in some cases, other food allergies or food sensitivities. They then took these individuals and, in a stepwise fashion, put them on a gluten-free diet, and then challenged them with gluten, and they identified 270-odd patients that turned out to have a response to the gluten in that their symptoms returned. This particular group was then further subdivided into 70 in which the symptoms returned only when they were given wheat, and the remainder of the group had symptoms return when they were given other food products as well. But what they were looking at is the response to the introduction of gluten, and this is it refers to the whole 276. And if you look at the graphs, you can see that in every case, once they were introduced to gluten, this was a double-blind placebo-controlled, remember, with a washout period, the symptoms returned only when they were given the wheat, significantly within the first week and progressively more so after 2 weeks, suggesting that there is, in fact, an entity of non-celiac gluten sensitivity. So I want to come to our next poll question now before we move on. And again, it's a true or false question if you go to the bottom of your screen. The question is gluten, that is the protein fraction of wheat, barley, and rye, we're talking about gluten, is this the ingredient that is responsible for the symptoms of non-celiac gluten sensitivity, true or false? I'll come to the poll question, the results in a minute. So I'd like to turn to the next slide, and this is really where we get into a debate about what is it that's causing the symptoms when you withdraw gluten from the diet. On the one hand, there are those that say it is the gluten or possibly amylase trypsin inhibitors. Some people even think that this may be a very early manifestation of celiac disease. In some of these patients, they talk about them being celiac-like. They haven't yet developed their antibodies or histological changes. On the other hand, there's the group that think that it's not necessarily the protein fraction, but it's everything else that you remove from the diet when you go on a gluten-free diet. And this comes down to our FODMAPs, the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So let's look at the evidence for these two things. So first of all, the evidence that gluten is causing irritable bowel symptoms. There are a group of patients that you can study that when they are exposed to gluten have changes that are not in keeping with celiac disease, but it's significantly different from those in the control group who don't have symptoms. There's a definite increase in intraepithelial lymphocytes, not to the level of those with celiac disease, but certainly more than those who are normal controls. About half of these patients can have elevated anti-Gluten antibodies, which is lower than those with celiac disease, but certainly higher than those in the control group. You can also show that these individuals have an increase in their toll-like receptors 2 and a decrease in FOXP3, which is very different from celiac disease, and again also different from controls. There's a lot of debate about whether these individuals do have increased permeability, mucosal permeability. Some studies show they do, others show they don't, so that's a little bit debatable. But also the role of HLA DQ2 and DQ8 is very interesting. The general population, this occurs in about 30%. The celiac population, it's 100% if you take the DQ2 and the DQ8. In those with non-celiac gluten sensitivity, it's about 50%. So again, higher than controls, but lower than the celiac disease. And people have considered this as indication that it's the gluten that's causing the problem. Let's come to the result of our poll question and just see what the results were. Barry, can you tell us?
Sure enough. I just want to remind everybody, if you have any questions for any of the presenters tonight, please go ahead and type them into the chat box, and we'll try to address them at the end of the program. So Dr. Hill is always a little bit tricky, and the answer to this really isn't known. and that was reflected in the answers of our participants. 57% felt that the answer to the question was true, and 43% believed it was false.
Very interesting and not surprising, so that's good. Let's go on to the next slide and then look at the evidence for whether it's the FODMAPs that are causing the irritable bowel symptoms. And here was a study where they looked at two groups of patients, 39 in the one and 43 in the other. The one group got the standard dietary recommendations. The other group was put onto a low FODMAP diet. And as you can see, those that went onto a low FODMAP diet had an improvement in their symptom scores across the board. So improvement in symptom response, decrease in bloating, decrease in pain, and decrease in flatulence, significantly more so than those that were on the standard diet. And then on the next slide is what I found very interesting. So you'll remember that the study that I quoted earlier saying that it was non-celiac gluten sensitivity was by Bersakiski from Australia. Well, much to these people's credit, they went back and looked at another way of looking at this subject, identified 37 patients that had self-diagnosed themselves as being non-celiac gluten sensitivity. What they did first was put the whole group onto a low FODMAP diet for 2 weeks, and then sequentially went back and challenged all 37 with 16 grams of gluten as a protein component, 2 grams per day of gluten, or 16 grams per day of whey. Demonstrated that it was really the low FODMAP diet that improved their symptoms, because challenging them with the gluten or whey did not precipitate their symptoms again as long as they were kept on a low FODMAP diet. So their results said a consistent reported improvement on a low FODMAP diet, no evidence that gluten at either dose causes symptoms. Very interesting. And the final slide that I'll show you is just a nice little table that probably explains why when you put somebody on a gluten-free diet, you do improve their symptoms in some cases. This illustrates the amount of fructans and oligosaccharides that occur in various foods, and in the green boxes are all those that are gluten-free. And with the exception of the haricot beans, which will probably give most of us the opportunity to let one rip, you can see that the fructan and oligosaccharide content is much higher in those foods that contain gluten than those that are gluten-free. So my final slide is our conclusions. It really does look as though both gluten and FODMAPs can cause irritable bowel-like symptoms. Maybe there's a small subgroup where it's specifically the gluten, and possibly a larger group where it's the FODMAPs. So the FODMAPs appear to be more likely to be causative in many people. And a low FODMAP diet is probably easier and more palatable than a gluten-free diet, a strict gluten-free diet. So perhaps a trial of a low FODMAP diet is reasonable, providing you first excluded celiac disease and wheat allergy in people who have irritable bowel syndrome. And with that, I'm going to hand you back to Barry and let him sum up and wrap up for us. Barry?
Thank you, Ivor. Well, I'd like to pose a few questions to our presenters. And I'd like to start with Rob Shulman. It's often thought that disaccharidases are the kind of best analysis for carbohydrate malabsorption, but in your polling question, you felt that diet and symptom records were best. Do you want to comment about the utility of duodenal biopsy and disaccharidase analysis?
Right. So I think for Sucrase-Isomaltase, as I mentioned, you don't usually need biopsies to make a diagnosis, but I think that's one condition where if you were going to do biopsies, that would be one thing that might be helpful to do. If there was some issue because you weren't sure about the diet, how the relationship with the diet, or you did the breath test and the breath test didn't seem to be really clear-cut and you still had a strong suspicion, then I think doing enzyme activity in that condition could be helpful. For lactase, as I mentioned, the breath test really is pretty reliable. As we saw from that adult study I showed, that when you're looking for lactose malabsorption, again, the sensitivity, specificity is really pretty good. And again, that doesn't tell you whether or not somebody has intolerance, but it does tell you whether they have malabsorption. And you're not going to tell anything more than that from doing the disaccharide or doing the lactase activity from a biopsy either. And again, for certain populations, for example, as I mentioned, the Asians, blacks, if you did biopsies and then in a 12-year-old or a 14-year-old, you'd expect to see very low lactase activity in all those individuals. And of course, for fructose, since that's actually absorbed by facilitated transport, you're not going to be able to really diagnose that at all by biopsy.
And Rob, one of our participants asked the question, is there any new information on genetic testing for adult-type lactase deficiency?
Yeah, there are two mutations that are associated with the persistence of lactase activity. So in other words, if you have these, and I should say that, I mean, they're actually mutations. So the normal course of the world population is to lose lactase activity. And so you actually have a mutation that allows you not to lose lactase activity. And you can actually test for those two mutations. And if you have one of those two, it means you have persistence of lactase activity or predicts persistence of lactase activity. But again, it's rarely needed because, as you might expect from the breath test, you would expect to have a negative breath test in that situation.
Great. Ivor, one of our participants asked, what's a good length of a dietary trial if you're suspecting that there's either non-celiac gluten sensitivity or a carbohydrate issue?
The figure that I've seen written out there a couple of times is 2 weeks. 2 weeks is an adequate trial. If it was definitely related to either the gluten or the whatever else comes out of the diet, the FODMAPs and that, you should have a symptomatic response within a 2-week period. So I think that's reasonable.
Now, given the fact that so many patients are now coming in thinking they have gluten sensitivity, and many of them are either asking for guidance and providing that kind of diet for their child or for themselves, do you think that everyone should be put on a gluten-free diet that has IBS symptoms to see if they have improvement?
So, Barry, I think this is one of the biggest problems we're facing at the moment, is that it's not just the lay public that are sometimes putting themselves on a gluten-free diet, but I'm having many referring physicians who are starting children on a gluten-free diet without doing adequate testing. Come back to saying that I don't think this is a condition that should be considered until celiac disease and wheat allergy have been actively excluded. Once you've excluded those with the appropriate testing, and you're still considering that it may be an issue, that is a time I might consider a trial, but certainly not before.
That's great. And Sam, could you just elaborate a little bit on what the biopsychosocial model is?
Yes, thank you for the question. All of us in general are brought up in what we call the medical model, which has a very organicistic approach, meaning you have a differential diagnosis, you do a test, the test gives you an answer, and then you give a cure. For example, you have a sore throat, you do a culture, you have strep, you give antibiotics, and it goes away. That's the medical model. The biopsychosocial model refers to most of the diseases we actually see every day, in which the disease is occurring in an individual who has a genetic background, has had environmental influences and genetic makeup that has been influenced by his early life activities, and then develops symptoms after there's some type of trigger. And the trigger could be an infection or could be trauma, and then could be also associated with some psychological problems. And this results in maladaptive behavior to the pain and to the results that need to be taken into context. So this is more an approach to the whole individual in his own context with his own genetic makeup and all the influences that are occurring to influence his disease activity and perception of the pain.
A quick question for me is, what testing do you recommend for a wheat allergy? Well, there's the cell-mediated type, which is classic celiac disease, and we all know the approach to both screening and ultimate diagnosis of celiac. But what you may be referring to is IgE testing for wheat. A significant proportion of immediate type reactions can be elicited by wheat, and you can identify that either with immunocap testing of blood or skin prick testing. And again, that's one of those foods that, if positive, then you want to do a controlled challenge, because you're going to confirm that reaction, and also start a diet that's going to be rather restrictive in the patient, given the wide occurrence of wheat within the schools and most children's reach. So again, it's important to look at IgE testing in that, but also to confirm reactivity with some type of controlled trial. We have a number of other questions, but we've kind of run out of time here. We have to close now, but I want to invite you to stay on the unmoderated chat box. This will remain open for the next hour to allow participants to share cases and comment with each other. I want to thank the faculty for their excellent presentations. Thank NASPGHAN and NASPGHAN Foundation for their sponsorship, and Diax and QOL Medical for providing support for this program. I would in particular like to thank the participants for attending the program and your participation through the questions asked. Like all of our webinars, this program will be archived on the NASPGHAN and the NASPGHAN Foundation websites for future viewing. And at this point, I'd like to wish you all a good night.